Video 10 Social Determinants of Health ESDO Area CHES Subcompetencies 1.3.3. Review the learning objectives for this video. Now we are getting into a topic that is absolutely fundamental to modern public health, and honestly one that I think will change the way you see health outcomes. We are talking about social determinants of health, commonly abbreviated as SDO. These are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health outcomes, functioning, and quality of life outcomes and risks. This concept is fundamental to the CHES exam and to everything you will do in practice. The Healthy People Framework organizes social determinants into 5 key domains. The first domain is economic stability, which includes factors like employment status, income level, food security, and housing stability. Research consistently shows that poverty is one of the strongest predictors of poor health outcomes. People with lower incomes face barriers to healthy food, safe housing, quality health care, and stress management. The second domain is education access and quality. Educational attainment is strongly linked to health. People with higher education levels tend to live longer, experience fewer chronic diseases, and engage in more health-promoting behaviors. This domain also includes health literacy and language barriers that affect a person's ability to understand and act on health information. The third domain is healthcare access and quality. Having health insurance is important, but access goes beyond coverage. Are there enough providers in the community? Do providers offer culturally and linguistically appropriate care? Are clinic hours compatible with working schedules? The fourth domain is neighborhood and built environment. Where you live profoundly affects your health. This includes the physical condition of housing, access to public transportation, proximity to grocery stores versus fast food outlets, exposure to environmental pollutants, and the safety of streets and parks. The fifth domain is social and community context. This includes social cohesion, civic participation, experiences of discrimination, and the strength of social support networks. Social isolation, racism, and community violence all contribute to poor health outcomes. For the certification exam, you need to understand that these 5 domains interact with and reinforce each other. A person experiencing unemployment may also lack health insurance, live in substandard housing, and face food insecurity all simultaneously. Seeing these connections is what makes you an effective health educator. Now let me help you untangle 3 related terms that appear frequently on the CHES exam. These are health disparity, health equity, and health inequality. They are often confused, so let us take the time to clarify each one carefully, because getting this right will pay off. A health disparity is a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. The key word here is preventable. Health disparities are not simply natural differences in health between groups. They are differences that result from systemic disadvantage. For example, the fact that African American men have significantly higher rates of prostate cancer mortality than white men is a health disparity because the difference is driven by unequal access to screening, treatment, follow-up care rather than by biology alone. Health equity is the aspirational goal, and it is a powerful one. Health equity means that every person has a fair and just opportunity to be as healthy as possible. Achieving health equity requires removing obstacles to health such as poverty, discrimination, and their consequences, including lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. Notice that health equity does not mean equal health outcomes for everyone. It means equal opportunity for health. Some differences in health outcomes will always exist due to genetics and personal choices, but disparities rooted in social disadvantage should not. Health inequality is a broader term that refers to any measurable difference in health between groups, regardless of whether the difference is unjust. For example, the fact that younger adults generally have lower rates of arthritis than older adults is a health inequality, but it is not a health disparity because it is not caused by social disadvantage. For the exam, remember this hierarchy, and I think this will really help you. Inequalities describe any difference, disparities describe differences linked to disadvantage, and equity is the goal of eliminating those disadvantage-driven differences. Once you see it that clearly, those exam questions become much more manageable. When assessing the social determinants of health in a community, there are three critical dimensions of service delivery that you need to evaluate. These are availability, accessibility, and acceptability. They are sometimes called the AAA framework, and they appear regularly on the CHES exam. Let me walk you through each one. Availability asks a simple but important question. Does the service or resource exist? Before you can assess anything else, you need to know whether the health services, programs, facilities, and resources your community needs actually exist within a reasonable geographic area. For example, a rural county may not have a single mental health provider within 50 miles. The resource is simply not available. Accessibility goes deeper. Even when a service exists, people must be able to reach it. Accessibility includes geographic accessibility, meaning how far people must travel. It includes financial accessibility, meaning whether the cost is affordable given people's income and insurance status. It includes temporal accessibility, meaning whether operating hours work for the population you serve. If a diabetes clinic is only open from 9 to 5 on weekdays, employed adults may not be able to attend. And it includes informational accessibility, meaning whether people know the service exists and how to access it. Acceptability addresses the cultural and personal appropriateness of services. A service may be available and accessible, but if it is not acceptable to the priority population, it will not be used. Acceptability includes whether services are offered in the language of the community, whether providers understand and respect cultural beliefs and practices, whether the physical environment feels welcoming and safe, whether services are delivered in a manner consistent with community values. Here's what I really want you to take away from this. All three dimensions must be present for services to be effective. A program that is available but not accessible will have low participation. A program that is accessible but not acceptable will be rejected by the community. Your needs assessment must evaluate each dimension independently to identify where the gaps exist. This framework gives you a powerful lens for understanding why good programs sometimes struggle. Let us keep building on this. Read the scenario stem aloud. Give students 30 seconds to consider options before advancing. The correct answer is B. The correct answer is B because the scenario describes two distinct barriers. First, the clinic hours conflict with the work schedules of hourly employees, which is an accessibility barrier related to temporal access. Second, services are only in English for a predominantly Spanish-speaking population, which is an acceptability barrier related to language and cultural appropriateness. Option A is incorrect because the service does exist in the neighborhood, meaning availability is not the issue. Option C assumes a knowledge deficit without evidence. Option D introduces an unsupported assumption about social stigma. Summarize